I'm Dr. Lawrence Rudsky from the Jewish General Hospital in McGill University, Montreal, and I'm pleased to present to you a talk entitled Echocardiographic Assessment of the Right Heart in the Intensive Care Unit. Echocardiography is assuming an ever-increasing role in the management of the patients in the intensive care unit. It's used in the diagnosis of the cause of shock or hemodynamic instability, etiology of respiratory failure or hypoxemia, the follow-up of patients to determine their prognosis, and in prognostication of patients. The aims of this presentation are to review the basic anatomic and physiologic principles related to the interaction of the right atrium, right ventricle, and pulmonary circuit, the concepts and methods of hemodynamic measurement, how to evaluate the right atrium and right ventricular size, how to evaluate the right ventricular systolic function, to discuss some things that we see in the right heart on echo, and then to finally go through some right heart pathology diagnosed by echo in a case-based format. The right heart is situated in an anterior position. Therefore, it's often seen better by transthoracic echo, as it is in the near field of the echo study. The right heart is composed of the right atrium, the right ventricle, which in itself is composed of three segments, the inlet, the body, and the infundibulum. Also in the right heart, we have the tricuspid valve, which has three leaflets and papillary muscles, and the pulmonic valve. The right ventricular volume is slightly greater than that of the left ventricle. Since the left heart only pumps what the right heart sends it, if the right ventricle is bigger, then the right ventricular ejection fraction must be smaller. Despite the larger volume of the right ventricle, the right ventricular mass is only 1/6 of that of the left ventricular mass. The right ventricular myocardium is made up of two layers of muscle fibers. There are superficial circumferential fibers, which serve as a bellows, kind of like to stoke a fire. Then there's a deep longitudinal layer of fibers, which are responsible for the descent of the base. As opposed to the left ventricle, which has spiral fibers, the right ventricle lacks these spiral fibers and therefore lacks the ringing motion that the left ventricle has. Once the blood is ejected out beyond the pulmonic valve, it has a long journey until it gets to the left atrium. In fact, it takes several beats to traverse the many levels shown on this slide. The red line demarcates pre- versus post-capillary causes of pulmonary hypertension. But don't forget the left heart. Most etiologies of pulmonary hypertension and of right ventricular dysfunction are in fact related to left-sided conditions, including left ventricular systolic failure, valvular heart disease, severe diastolic dysfunction, and others. The above is illustrated in the recently revised classification of pulmonary hypertension, whereby the box in the red looks at pulmonary hypertension related to left heart disease. Shifting to physiology, I'd like to introduce the concept of Ohm's law, where pressure is proportional to flow times resistance. This is critical to understanding how the right heart pumps and why it may fail. Recalling the bellows analogy, one must be reminded that the right ventricle works as a volume organ rather than a pressure pump. With exercise, the right ventricle can quadruple the cardiac output by increasing the heart rate threefold and by doubling the stroke volume, but with little increase in systolic pulmonary artery pressure or in pulmonary vascular resistance. This is the result of a tremendous ability to recruit additional vasculature. Myocardial oxygen demand is determined by preload, afterload, and contractility. Preload is a function of wall stress, which is described by Laplace's law. Because the lung circuit can recruit more vasculature with increased cardiac output, the right ventricle doesn't face the same challenge as the left ventricle. But when the lung can't recruit any more, the right ventricle has an adaptive response with hypertrophy, and the septum remodels its curvature in order to normalize the wall tension. This is seen echocardiographically as right ventricular hypertrophy and a D-shaped septum. The septum doesn't have a mind of its own. It just passively follows the pressure gradient between the right ventricle and left ventricle. If the right ventricle is significantly pressure loaded, the flattening will be systolic or throughout the cardiac cycle, whereas if it's volume loaded, the flattening will be predominantly diastolic. RV coronary perfusion occurs both in systole and diastole, but as right ventricular systolic pressure increases, there's lesser a pressure gradient between the coronary diastolic pressure and the right ventricular pressure. As a result, when the so-called adaptive responses reach a certain tipping point, the right ventricle is faced with a double whammy of increased demand and decreased supply. We're now going to cover some of the pulmonary hemodynamics. Keeping in mind how the right ventricle pumps into the pulmonary circuit, let's go back to the clinical arena and look at how we can measure parameters of right heart function. There are both quantitative and qualitative parameters. The quantitative parameters that we can measure are right atrial pressure, right ventricular systolic pressure, pulmonary artery systolic pressure, pulmonary artery end diastolic pressure, stroke volume, cardiac output, and cardiac index. And qualitatively, we can get an idea of RV function by RV size. Let's start with a seemingly simple right atrial pressure. The values used to estimate right atrial pressure until recently are published in the following document. As you can see, the values are based on an estimation of inferior vena cava diameter and inferior vena cava collapsibility during respiration. Based on these two values, a right atrial pressure is assigned. In the ICU setting, there are a number of differences with our usual echo evaluation. Firstly, many patients are being ventilated with positive pressure ventilation. The IVC in this setting is usually dilated. In fact, if the IVC collapses during the respiratory cycle, it may represent hypovolemia. Secondly, in many patients in the inferior vena cava, a right atrial line is available, which can be transduced to directly measure the right atrial pressure. This method is preferable when available. The values from the chamber quantification guidelines were revisited by Brennan et al., correlating again IV size and collapsibility with measures of right atrial pressure. As you can see, there are 9 different categories or combinations. In order to make estimation simpler, the most recent ASEUII guidelines on echocardiographic assessment of the right heart recommended the following algorithm, again, based on IVC diameter and collapse with sniff, and is divided into normal, intermediate, and high. As you can see, the normal range is between 0 and 5 millimeters of mercury, intermediate is between 5 and 10, and high is 15. In order to have standardization across many labs, it was selected to use the mid-range of each of these ranges. So normal would be 3 millimeters of mercury, intermediate would be 8 millimeters of mercury, and high would be 15 millimeters of mercury. And there are ways for the intermediate to assign it to either a higher or lower category. There are many situations in the intensive care unit whereby patients are hemodynamically unstable with hypotension and tachycardia. Often the initial approach to this is a fluid challenge. Some patients, however, may not benefit from this approach. In those subjects with acute hypovolemia, fluid resuscitation is often helpful. In other subjects, such as those with sepsis, this is often best combined with an alpha agonist. Still, in some patients, such as those with ARDS, fluid may actually worsen their status. In addition, stroke volume response to fluid expansion is variable and depends in part on the cardiac function. From a physiologic point of view, the right ventricle is often regarded as a permissive pump. In the absence of disease and abnormal afterload, the right ventricle will pump whatever it receives. This physiologic principle is illustrated in the interaction between the venous return curve, which is the curve that starts off flat on the left and angled down, and the cardiac function curve, which is the curvilinear line that starts on the left and curves towards a plateau on the right. The above figure shows an area where the cardiac output is return limited to the left, as opposed to cardiac limited on the right, whereby no matter how much fluid is infused, the cardiac output would not further increase. It would certainly be helpful if we had a simple, non-invasive method to predict response to fluid expansion. Unfortunately, many established tools do not predict the outcome of a fluid challenge. These include CVP, pulmonary capillary wedge pressure, left ventricular end diastolic dimension, and right-sided E-day ratio. Two techniques that have been used are respirophasic change in stroke volume by pulse Doppler and respirophasic change in IVC diameter by transthoracic echo and by SVC diameter by transesophageal echo. In spontaneous breathing, with inspiration, intrathoracic pressure drops. The right heart fills more, and there is a resultant increase in right-sided stroke volume. With positive pressure ventilation, the opposite occurs. The degree of variation depends on what point you are on the Frank-Starling curve. The same principle occurs on the left since the ventricles are coupled. If there are large ventilator-induced changes in stroke volume on the left side, there is preload reserve, while if there is little or no change, then the patient is preload independent. Either the tank is full or there is significant left or right heart pathology. Interestingly, the variations with respiration are not affected by pharmacologically altering the afterload. This further supports the hypothesis. What value is significant? Most studies report a stroke volume variation of 12 to 13% for aortic Doppler. Dealing with the vena cava, we apply the same physiology, but it's more simple to conceptualize. With the caveat that this may not be reliable in acute cor pulmonale, a change in IVC diameter by transthoracic echo of more than 12 to 18% variation with positive pressure ventilation suggests preload responsiveness, defined as an increase in cardiac output with volume infusion. First, the superior vena cava by transesophageal echo seen in the bicaval view, increase of or collapsibility of 36%, or change in distensibility, correlates with improved cardiac output with volume expansion. In this image, you see an IVC which collapses nicely, suggesting fluid responsiveness, and this patient was being ventilated with positive pressure ventilation. Here we're looking at a bicaval view by transesophageal echo, focusing on the superior vena cava to the right. You can see that there is little variation in its diameter when the ventilator delivers a tidal volume, both visually and by measuring. This patient had already received a large number of packed red cell units, fresh frozen plasma, platelets, and crystalloid, and is therefore not volume responsive. Moving on to pressure measurements, one of the fundamental equations that we use in echocardiography is the simplified Bernoulli equation to calculate pressure drops between two chambers. It states that right ventricular systolic pressure, or systolic pulmonary pressure, or change in pressure, is proportional to 4 times the velocity of the jet squared. In the case of the tricuspid regurgitant signal, the right ventricular systolic pressure, the pressure gradient between the right ventricle and right atrium, is proportional to 4 times the velocity of the tricuspid regurgitant jet squared. On this slide, we see an imperfect example, and I'll point out its deficiency later, why by 4 times the TR max velocity squared gives you a pressure drop of 110 millimeters of mercury. If the CVP is estimated at 15 millimeters of mercury, as can be seen by the dilated, non-collapsing IVC on M mode to the right, the estimated right ventricular systolic pressure is 125 millimeters of mercury, and the systolic PA pressure is the same in the absence of pulmonic stenosis. The tricuspid regurgitant envelope is often weak or incomplete, as can be seen in the panel on the left. This can be enhanced with agitated saline or, even better, an air-blood mix, as can be seen in the panel on the right. When compared with right heart catheterization, the tricuspid regurgitant velocity versus the directly measured or transduced pressure improves from a correlation from an R value of 0.4 without contrast to 0.92 with air blood contrast. But you have to beware of over-exuberant contrast-enhanced TR jets. Blooming of the Doppler signal may result in significant overestimation of the right ventricular systolic pressure. In the example that I had shown initially, while the contrast was not used, the extreme outer edge of the envelope was taken and the gains were not optimized, resulting in a significant overestimation of the SPAP. In this example as well, the SPAP without overgaining is 27 millimeters of mercury, but when the gain is used excessively, the PA pressure is overestimated as high as 45 millimeters of mercury. Is the TR jet always reliable? At the low end, there's often an overestimate, as demonstrated by the SOFIA study, while in a classic primary pulmonary hypertension epoprostenol study, it was found that at the high end, there were significant underestimates in 31% of patients. In another study, in an intensive care unit setting, there was both over and underestimation of the systolic PA pressure compared to right heart catheterization, but you can see the display only increases in the abnormal range of PA pressures in the area of more than 50 or 60 millimeters of mercury. Some patients don't have a measurable TR signal. One key point is that it's better not to report a PA pressure than to report an erroneous one from a trace jet. If no TR is available, one can use either the PI jet to obtain a mean or an end diastolic pressure. And if you have both of these, and they're both measurable, then you can back calculate the systolic PA pressure using the formula that mean PA pressure is equal to 2/3 diastolic plus 1/3 systolic pressure. There are a few cautions around the assumptions involved in systolic PA measurement. The first assumption is that RVSP is the same as a systolic PA pressure, and that the RV pressure is the same as the PA pressure. This doesn't work if there's obstruction between the right ventricle and the pulmonary artery. This occurs in pulmonic stenosis, in double-chambered right ventricle, or in subpulmonic stenosis. The second assumption is that the simplified Bernoulli equation is accurate at all levels of tricuspid regurgitation and all conditions of the right ventricle and right atrium. The equation is known not to be accurate in the setting of laminar flow, such as with wide-open tricuspid regurgitation. The third assumption is that the value chosen to represent the right atrial pressure is accurate. And we know this is not always accurate, particularly in the setting of positive pressure ventilation. In the setting of very high right atrial pressure, it may be more accurate to use the transduced pressure from a right atrial catheter. Here we see a solid, mild tricuspid regurgitant signal yielding a right ventricular right atrial gradient of 43 millimeters of mercury. But when we further evaluate the right heart, we see that there's a gradient of 37 millimeters of mercury across the pulmonic valve. This patient, incidentally, a status post-Ross procedure, has developed some degree of pulmonic stenosis. So we have to remember to subtract this value in estimating the PA pressure. Let's now move from hemodynamics to heart chamber size, though there's certainly some connection between chamber size and chamber pressures. The left atrium in its volume has been referred to as the hemoglobin A1C of the heart. The right atrium has been neglected, but physiologically it should too reflect acute and chronic states of the right heart. The recent guidelines document has defined normal values preferring area to dimension. A right atrial end-systolic area of greater than 18 centimeters squared represents an abnormally enlarged right atrium. While there are no validation studies in the intensive care unit, this may become an important measure in the future. Another important and seemingly simple measure of the right ventricle is the right ventricular size, yet practically the assessment of this is not straightforward. It can be measured in the parasternal long axis and parasternal short axis with an upper reference limit of 26 millimeters distal and 33 millimeters proximal, or in the apical forechamber with an upper limit of normal of 42 millimeters, or less than 70% of left ventricular dimension. Unfortunately, commonly it ends up being a gestalt assessment. That is, does the RV look big? Start. This slide illustrates this point. In the left panel, we have a relatively normal-looking right ventricle. In the lower right panel, the RV appears small. And in the upper right panel, the RV appears dilated. For those of you trained to use all the information on the screen, you'll see that these images are actually just minutes apart and are all on the same subject, with the difference being slight changes in the probe rotation. This cartoon demonstrates the basis for this. The right ventricle is pyramidal shaped, and when cutting through it from the apex, you can bisect it through the apex, giving the largest dimension, or at various other levels, giving intermediate or small sizes. As you can see from the above, and from what you'll see later, there's a lot of variability in measures of cardiac structure and function. In order to set some common basis for measurements, the ASEUII developed a guidelines document. This document aimed to establish which echocardiographic measures should be made and provide normal values based on the best available data. In these guidelines, the RV focus view was recommended as the preferred view to measure right heart dimensions. This is obtained by emphasizing the right ventricle from the apical forechamber view by slightly rotating the probe towards the right ventricle. Based on the available literature, the right ventricular basal diameter had a 95th percentile upper reference value of 42 millimeters, suggesting that if the right ventricle measured more than 42 millimeters, it was likely enlarged. To make the point that guidelines are not perfect, here we see a case of significant RV dilatation, whereby the RV is much larger than the left ventricle, but still measures within the so-called normal range. This is not infrequently seen in patients with significant pulmonary hypertension. And in this case, the RV should be called dilated, despite the fact that it measures within the normal range. How good or bad is echo? A study by Lai et al. Compared standard echo views of the right ventricle and then set up similar planes from MRI data sets. It became clear that there are significant differences between echo and MRI in these measurements. And from this study, we also saw that things only got worse when the right ventricle is abnormal. What about transesophageal echo, a modality that's frequently used in the intensive care unit? The right ventricle area is usually measured from the mid-esophageal forechamber view. You can also look at right ventricular area from its maximum short axis dimension. There are no specific normal values by transesophageal echo as opposed to transthoracic echo, and it often comes down to the eyeball or gestalt approach. The septal curvature is normally concave to the left ventricle, but if it's flattened or reversed, this is suggestive of pressure and or volume overload. From the acquisition of a volume by 3D echo, you can cut the volume in various planes and obtain a reproducible and relatively accurate volume. But there's often problems with image quality, difficult planes to get at. There are still some validation issues, and certainly we all know that the availability is not universal. Let's now look at how to assess right ventricular systolic function. It's interesting to look at the hemodynamic definition of right heart failure. It's defined as right atrial pressure of more than 8 to 10 millimeters of mercury, right atrial pressure to wedge pressure greater than 0.8, and or a cardiac index of less than 2.2 liters per minute per meter squared. Notice how it's hard to see how these particular parameters deal exclusively with the right heart. We've touched on the concept of stroke volume before in the evaluation of fluid responsiveness. Of course, stroke volume is one of our classic measures of function as it relates to both cardiac index and cardiac output. Recall that due to the concept of ventricular coupling, left-sided cardiac output has to be the same as right-sided cardiac output in the absence of significant shunt. We'll therefore briefly review left-sided stroke volume measurements, as it's much simpler to measure on the left side. Stroke volume can be measured either by change in volume in the left ventricle or the right ventricle from end diastole to end systole. From validation literature versus MRI, most echo methods underestimate end diastolic and end systolic volumes, and therefore also underestimate stroke volume. This can be reduced. This underestimation can be reduced by using echo contrast. The other method is the Doppler method that we are all familiar with, whereby stroke volume is equal to the cross-sectional area times the velocity time integral. This can be done both on the right or the left side, but it's more reliable on the left side. When there's significant tricuspid regurgitation, the correlation with thermodilution catheter is poor, but this is because the catheter-based method is more incorrect. One of the great advantages of the echo methods of assessing cardiac function is that in 2011 we all believe that seeing is believing. The echo will tell us right away, is the reduced stroke volume related to a big, baggy heart with poor contractility, or is it related to an underfilled heart with adequate contractility? Or, as I mentioned before, is the PA catheter reading related to the presence of severe tricuspid regurgitation? Specific right-sided quantitative measures of cardiac function can be grossly divided into the two following categories, global or regional. And within the global, we have right ventricular ejection fraction, right ventricular fractional area change, DPDT, or myocardial performance index. And the regional, we have TAPSE, or tricuspid annular plane systolic excursion, velocity of the annulus by tissue Doppler denoted as S prime, strain or strain rate, or isovelocity acceleration. As mentioned before, there are new guidelines for the echocardiographic assessment of the right heart in adults, and within these guidelines, there are recommendations on these measurements. The summary table is Table 4 of this document, which demonstrates basic upper or lower reference values as may be appropriate for these different measurements. And this is actually the take-home message for RV systolic function of this document. Here we see the calculation of the fractional area change, which is calculated as the end diastolic area minus the end systolic area divided by the end diastolic area. In the panel on the upper left, we see an excellent RV contractility, whereas at the panel on the right, we see a very low RV contractility with a fractional area change of only 20%. When we look at the available data, we can see that the lower reference value would be a fractional area change of 35%, whereas values lower than this would be considered significantly abnormal. The tricuspid annular plane systolic excursion method, or TAPSE, is denoted in this slide, whereby we drop a mode cursor through the annulus of the tricuspid ring, and we measure the distance excursed by the tricuspid annulus by M mode. Here we see that it's 24.7 millimeters. And when we look at the available literature, the lower reference value is 16 millimeters. So a value of less than 16 would be significantly abnormal. The S prime time or the velocity of the tricuspid annulus, as measured by tissue Doppler, can be done either by pulsed tissue Doppler in the panel on the left or by color-coded tissue Doppler using offline analysis in the panel on the right. Only the pulsed Doppler method is currently recommended, and a lower reference limit of 10 centimeters per second is considered acceptable. The myocardial performance index, also known as the right-sided index of myocardial performance, or the TAE index, is a global estimate of both systolic and diastolic function of the right ventricle. It's based on the relationship between ejection and non-ejection work of the heart, and it can be done, again, by pulsed Doppler of the tricuspid inflow and tricuspid regurgitant jet, or the time between the A wave and the E wave, or it can also be done on a single heartbeat by pulsed tissue Doppler. And the values are different depending on which method you use. Using the pulsed Doppler method, an upper reference limit of 0.4 is the cutoff, whereas using the tissue Doppler myocardial performance index, an upper reference limit of 0.55 is considered abnormal. Strain can be done using 2D or, again, color-coded tissue Doppler. This slide is included just to show that there are some values. However, there are wide reference limits around the upper and lower reference values, and that currently RV strain is not recommended. The ejection fraction is a universally accepted method of describing cardiac function, despite its many limitations. Due to the complex geometric shape of the right ventricle, the RV ejection fraction is more complex to measure and requires a three-dimensional approach. Using several different algorithms, the RV ejection fraction can be calculated with a lower reference limit of approximately 44%. This slide shows some of the advantages and disadvantages. As mentioned before, the concept is widely accepted, and there is some prognostic information in heart failure, in valvular heart disease, and congenital heart diseases. Disadvantages include inaccuracies and variability in technique. There are many different techniques. The ejection fraction, just as on the left side, is also load-dependent, and it may not represent true contractility, such as in the example of significant tricuspid regurgitations. This slide shows the recommended methods and normal references of the guidelines on the echocardiographic assessment of the right heart, and it is recommended that TAPSE, S prime, fractional area change are the methods of choice. Myocardial performance index can be used, but is not recommended to be the sole method of quantitation of RV function. So in summary, when you assess the right ventricular systolic function, it should be a combination of your eyeball, what does the RV systolic function look like, but also one should include methods of quantification. Now let's look at some of the structures within the right heart or objects that you might see. You might see a prominent eustachian valve or Chiari network. You can also see them foreign objects such as a pacemaker or ICD wire, a PA catheter, a dialysis catheter, or even an Amplatz or occluder. This is an example of one of these structures in the right heart. Here you see a pacemaker wire. Actually, there's two pacemaker wires entering the right heart through the superior vena cava. The atrial lead is hooking around. The ventricular lead is continuing on into the right ventricle. This is, in fact, the same patient actually several weeks earlier, whereby one sees another echogenic mobile mass on the pacemaker wire. This patient had bacteremia and a vegetation on his pacemaker wire. This patient, one sees a large mobile echogenic mass in the position of the eustachian valve. You can also see a catheter entering through the superior vena cava. This is a dialysis catheter which has traumatized the eustachian valve and has caused a thrombus to be associated with the eustachian valve. Finally, in this slide, we see a larger tube or a bigger hose in the right heart. This patient actually has a large catheter in place for ECMO. We're going to now have a quick look at the tricuspid valve, the right-sided AV valve stop. The tricuspid valve is made up of one continuous leaflet with indentations of the anterior, posterior, and septal. And although we usually think of it as being three leaflets, it has an annulus, which is D-shaped with a flatter portion along the central fibrous body, which is in fact contractile. Attached leaflets are chordae, which are attached to papillary muscles, for which there are usually three. And don't forget, just as on the left side, you have to factor in, when you're looking at AV valve function, the underlying right ventricular myocardium. This is just a cartoon and a picture of what the tricuspid valve looks like. There are many etiologies of tricuspid regurgitation, and is broadly divided, just as on the left side, into functional tricuspid regurgitation or primary tricuspid regurgitation. Functional is usually related to pathology of the right ventricle and is seen with in PAH or volume overload, such as with shunts and cor pulmonale, significant left heart disease, or right ventricular myocardial disease. Whereas primary tricuspid regurgitation is often rheumatic, myxomatous, can be seen with Epstein's anomaly, endocarditis, carcinoid or infiltrative diseases, traumatic such as in motor vehicle accident, and iatrogenic related to pacemaker wires or RV biopsy. As a general rule, in the setting of severe tricuspid regurgitation, if the PA systolic pressure is more than 55 millimeters of mercury, this is usually associated with anatomically normal tricuspid valves, whereas if the PA pressure is less than 55 millimeters of mercury, this is associated usually with an abnormality of the tricuspid valve apparatus. Here we see an example of severe tricuspid regurgitation. In the upper left panel, we have the RV inflow view with a large jet going from the right ventricle into the right atrium. In the upper right-hand view, we see systolic flow reversal going into the inferior vena cava and the hepatic veins, and in the lower panel, we see the same phenomenon by pulse Doppler in the hepatic veins, where we have a significant systolic flow reversals. The echocardiographic evaluation of tricuspid regurgitation is done both by Doppler and by 2D. By Doppler, we can measure PISAs, vena contractas, jet area over right atrial area, which has the same limitations on the right as it does on the left. Systolic reversal in the hepatic veins and regurgitant volumes or fractions can be calculated with significant difficulty. By 2D, we can look at the tricuspid valve morphology and look for tricuspid valve prolapse, presence of Epstein's, carcinoid, angiodilatation, etc. The American Society of Echo, in their guidelines from 2003 on the echocardiographic evaluation of regurgitant lesions, has published guidelines on how to grade tricuspid valve severity into mild, moderate, severe based on these different parameters. So we've covered all the theory. Now what about the real world that we see in the intensive care unit? Unfortunately, there's significant special imaging considerations in the intensive care unit. The intensive care unit often lacks windows, and so too do the patients. Usually when you have to echo someone who's recently had cardiac surgery, they have dressings in the midline, they have dressings in the epigastric area, and you often get one little window to stick your probe in. Image quality is also usually problematic because the patient is usually supine, and it's, again, difficult to get good windows because there's significant lung tissue between the thorax and the heart. And often, as a result, you need transesophageal echo to image the patients. And some hemodynamic measurements are more difficult to do by transesophageal echo. For example, measuring the velocity time integral of left ventricular outflow tract, or looking at the tricuspid regurgitant jet, which is often incomplete by transesophageal echoes. When one scans the intensive care unit, there is often precious little image seen. Sometimes virtually nothing is seen. And you have to think about what does and what doesn't transmit ultrasound waves. So we have to think about subcutaneous emphysema and pneumothorax, where both of these put air between the ultrasound probe and the heart, making it extremely difficult to see the heart. So when you can't see anything, think about air between your probe and the heart. Now I'm going to take you through a case of a patient who recently wasn't doing so well. So you get a call at 3 in the morning, and you always think about what's going through your mind, other than when you're racing and speeding at 100 miles an hour, that you're glad you supported the Policeman's Brotherhood and have a sticker on your windshield. The diagnoses they think about are tamponade, which can be either traditional tamponade or localized tamponade. RV hypokinesis, RV ischemia, or stunning, or what often is the case is an underfilled left ventricle that we often see in the little old ladies who've had their aortic valve replacements and have had significant concentric left ventricular hypertrophy. This is a recent 7 a.m. call. 76-year-old lady who's kind of like the first night after aortic valve replacement and tricuspid valve angioplasty for rheumatic heart disease. She has a past history of ITP, and you can see from her hemodynamic parameters and the medications that she's on, she's not doing so well. So the first person called was the fellow on call for echocardiography, and his image is that seen on the left, where it's difficult to see very much. Then you can see the lateral left ventricle is squeezing. The right ventricle looks a little bit dilated, but it's hard really to see what that wall is doing, and you can see there's a small effusion overlying the apex of the heart. Additional pictures are taken, and from these pictures in the right-hand panel, you can see that there is, in fact, significant right ventricular hypokinesis. From the panel on the left, we're looking at transtricuspid inflow. You can see there's very little variation in the velocity across the tricuspid valve, and when looking at the inferior vena cava, on the right, the inferior vena cava appears dilated, and when scanned in real time, there was no collapse. This patient, of course, as most sick patients early in their postoperative course is being ventilated by positive pressure ventilations. So the diagnosis was right ventricular dysfunction and was treated in the usual manner. Later on, the patient was doing significantly worse, and the patient was thought to have biventricular failure and low cardiac output syndrome. The Levophed was at a very high dose in order to maintain blood pressure, and we were asked, because there was a mild to moderate aortic regurgitation on the first transthoracic echo, to repeat an echo to see if an intra-aortic balloon pump might be beneficial and to see whether there was too much aortic regurgitation for this. A transesophageal echo was done, and in this loop you can see a tricuspid annuloplasty ring. You can also see that the right ventricle is in fact squeezing, and you see that there's only a small amount of fluid around the ventricular apex. So again, here the right ventricle is doing better, but the patient is in fact doing worse. So once we looked at the right ventricle and we were assured that it was not the problem, we continued to look around the heart. And in the panel on the left, you can see that there is actually a large echogenic mass compressing a significant amount of the right atrium. And when we go around to look at the superior vena cava at 130 degrees in the panel on the right, you can see that there's compression of the superior vena cava with turbulent flow coming through. So this a diagnosis of localized tamponade compressing a large amount of the right atrium was made. Because this patient was acutely crashing, the chest was opened up in the intensive care unit, and the surgeon scooped up large clots from the pericardium, and the patient improved subsequently. And as we say, the proof is in the pudding, or in this case, in the jelly. In this slide, we see what usual cardiac tamponade looks like. It's a large pericardial effusion. You can see pretty much in the three moving panels. In the upper left, we see compression of and collapse of the right ventricular outflow tract. In the upper right, we see a large effusion compressing the right ventricle, showing that making it very difficult for the right ventricle to fill. And in the lower left panel, we see a swinging heart with the right ventricular collapse. In the bottom right panel, we see significant transmitral inflow variation of the E-wave velocity, which also helps confirm our diagnosis. Tamponade in postoperative hearts, therefore, is a completely different animal compared to the traditional tamponade. Firstly, it has to be divided into early versus late tamponade, and using that comparison, we see some important differences. Early tamponade is much more commonly diagnosed by transesophageal echo with a negative transthoracic echo than in late tamponade. Also, early tamponade tends to be more loculated, either posterior to the LV, around the RV, around the RA or LA, whereas in late tamponade, it's much more commonly to be global. And when we looked at those traditional echo features of the RV collapse and the change in inflow velocity in early post-op cardiac tamponade, usually none of these findings are seen, whereas in late tamponade, they appear to be more common. Another situation which you may see involving RV dysfunction in the intensive care unit is illustrated in this case. Here we have a 75-year-old man with a history of total knee replacement 3 weeks prior and presents with dyspnea and pleuritic chest pain. The diagnosis is obviously not difficult to make based on the history, but let's look at it. The exam reveals a patient who was hypotensive, mildly tachycardic, and hypoxemic with an elevated D-dimer on labs, as well as an increased INR of 2.1, and the patient is mildly anemic. The chest X-ray demonstrates blunting of the right costophrenic angle, and all of this appears to be in keeping with the diagnosis of pulmonary embolisms. On echo, we see a moderately dilated and hypokinetic right ventricle with a so-called McConnell sign, which suggests more significant hypokinesis of the right ventricle with a preserved right ventricular apex. Patient also has mild tricuspid regurgitation and has a TR velocity of about just over 3 meters per second. With the IVC, gives you a right ventricular systolic pressure of 55 millimeters of mercury, and you can see the left ventricle is quite dynamic with an excellent left ventricular ejection fraction. And looking at the appropriateness criteria of echo, as this is important in the intensive care unit, the key points are that echo is not indicated to diagnose pulmonary embolism, but it is indicated to guide management in patients with pulmonary embolism once they have established the diagnosis. The echo findings in pulmonary embolus are dilated hypokinetic right ventricle, elevated PA pressures, increased tricuspid regurgitation. Left ventricle is often dynamic because it's underloaded. You can sometimes see a clot in the right atrium or in the right ventricle or in the right ventricular outflow tract, which is actually a pulmonary embolus in transit. Pertinent negatives that must be looked at are inferior wall motion abnormalities that can be seen with right ventricular infarct and pericardial effusions. Acute cor pulmonale, or acute right-sided failure, is seen in acute pulmonary embolus, severe hypoxemia, and ARDS. There's a sudden increase in right ventricular impedance, resulting in acute drop in right ventricular ejection and acute RV dilatation. The RV contraction becomes prolonged, resulting in an early diastolic septal shift towards the left ventricle. But because of the pericardial constraint, the right ventricular enlargement comes at the expense of left ventricular filling. We see this in an example here where there is a markedly D-shaped septum with a septal shift, and we can see that as well in the right-hand panel with severely dilated right ventricle, where the septum shifts with RV contraction. One of the conditions that sometimes is asked for in the intensive care unit when a patient is hypoxemic is to eliminate the presence of patent foramen ovale. In the panel on the left, you see a very mobile interatrial septum, where the septum primum seems to be lifting off the septum secundum. By color Doppler, you can see a significant jet crossing through this. It should be noted that you have to have a large PFO with significant amount of shunting in order to create any degree of significant hypoxemia. That can be supplemented by using agitated saline contrast, which should be done only if you don't see a large PFO with significant right-to-left shunt. In this case, you see a severely dilated right ventricle and right atrium with a small pericardial effusion. Agitated saline contrast is given, and you see a moderate amount of bubbles pacifying the left heart. Another condition that can involve the right ventricle, in which the patient can be quite ill, would be an acute right ventricular infarction. In the panel on the right, you can see in a mid-esophageal two-chamber view at 65 degrees, the anterior wall is preserved, whereas the inferior wall is significantly hypokinetic with regions of akinesis. This patient is actually on ECMO after an emergency salvage cabbage and on dobutamine. When we go to the mid-esophageal four-chamber view, you can see that the right ventricle is really akinetic and dilated. If one wants to be complete and be fancy, one can look at the right ventricle from many different views. The parasternal long axis shows you the right ventricular outflow portion. The RV inflow view shows the anterior and the inferior walls of the right ventricle seen in the lower left panel. The center panel, the subcostal, showing part of the RV free wall. In the upper right panel, we see the RV in short axis, and then we also see it in the lower right panel from the apical four-chamber view. So we can look at all these segments, and we should assess the right ventricle from all these different views, and we can even try and localize coronary artery supply. However, the importance of this has not yet been established, but in the right heart guidelines, there is a right heart wall motion plot with the coronary supply to these different walls. When dealing with ventricular dysfunction, which you can see in this transesophageal transgastric view on the left-hand panel. You can see a severely hypokinetic right ventricle. You still have to remember that you need to find the etiology. And in this case, the etiology is found by looking at the left heart, where in the left panel you can see that this patient has a bileaflet tilting disc mechanical mitral prosthesis, whereby both discs are stuck. So this patient's acute right heart failure was caused by mechanical mitral valve prosthesis dysfunction and acute left heart dysfunction. So in summary, as with all imaging modalities, the right heart parameters can and should be measured to ensure uniformity of reporting. There are basic measurements of right ventricular size, right atrial size, right ventricular systolic function, including TAPC, S prime, and MPI. The ICU setting, however, presents unique challenges. Patients are on positive pressure ventilation. They have altered hemodynamics. They have poor image quality and limited windows. We often need transesophageal echoes, and unfortunately, we lack normal values for transesophageal echo. It's critical that one has a strong knowledge of physiology and anatomy as well as clinical information. If you don't know what's going on, call the surgeon and find out what has been done. This will greatly enhance your diagnostic accuracy. You have to be familiar with the echo appearance of tamponade, including the localized postoperative tamponade, what cor pulmonale looks like, what right ventricular dysfunction looks like, and always remember to look for etiology, and that includes the neglected so-called left heart. And a final point, we always say a picture is worth 1,000 words. Well, here, echo allows you to see the heart in real time, and rather than just at the end of a pressure transducer. So instead of a picture being worth 1,000 words, here we have an echo image being worth 1,000 hemodynamic tracings.